Hi everyone, this is Neel Raithatha here, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iCLEARscope endoscope. And this is the reason why I feel an endoscope is in a league of its own when it comes to earwax removal. And I'll give you the patient's backstory. So they recently had their ears irrigated at their local GP practice, and although they said a lot of wax came out, they walked out feeling that their ears were even more blocked. And the nurse who performed the procedure said that all the wax had been removed. Now, most GP surgeries use an otoscope to examine the ear, and the otoscope is essentially an ear torch with a slight magnification, and it's got an ear specular. The problem in this case is that this patient has got an extremely bendy ear canal and an extremely prominent anterior recess. If you look at the right hand side of the ear canal protrudes inwards to the middle of the ear canal, and then it widens back to the right, and it creates a recess there, and we call that the anterior recess. And without an endoscope, it's extremely difficult to visualize this. So what had happened, I suspect, during the procedure was that when they were irrigating the ear, although they got some of the lateral wax out, it's possibly pushed some of this wax into the recess, and it wasn't visible to the nurse. Now, I also initially examined this patient's ear using the wax scope, and in fact, I've got the video, I've attached it to the end of this procedure, and I could just about see the tail end of the wax. I also examined the patient's ear using my ENT operating microscope, and I used some head loops, and with all three, you could just about see the tail end of the wax, and hence why I reverted to the endoscope for this. And the reason why an endoscope is so useful in procedures like this is, first of all, the lens, the magnifying lens of the endoscope is actually inside the ear, hence the name endoscope. And for that reason, we can angle the endoscope towards the anterior recess. With an ENT operating microscope, or head-worn loops, or even the wax scope, the magnifying lens is external, and there's only so much you can stretch and straighten the ear canal using the specular. And if you've got someone with an extremely bendy ear canal, it's near impossible to visualize in the anterior recess. And the second reason, why an endoscope is so good is because an endoscope has an extremely wide field of view. They have a negative lens on the distal lens, so where the magnifying lens is, just beyond that, there's almost like an inverted lens, and that almost gives you like a fisheye view of the ear. So you can't compete with an endoscope in terms of field of view. And even with an endoscope, it's very difficult still to fully examine into that. Now, the slight issue that we had was that this wax was very mushy, and it was embedded against the eardrum, making it very difficult to suction. So although I managed to make contact with the wax using the fine end suction tip there, it wasn't suctioning away, it was embedded and impacted. So I applied some drops just to soften that, and I've got quite a bit out already. The other slight challenge that we had, apart from visualizing and gaining access, is that you want to make sure you don't bump into the canal wall on the right hand side. If we do, it would be very uncomfortable for the patient. So what I had to do is bend and curl the end of the fine end, meaning that the tip can approach the wax, but without making contact with the bony part of the ear canal. It's a little trick that I learned from an ENT colleague of mine, Darius Rajali, many years ago, and it works really, really well. So at this stage, the patient felt they could hear a lot better, but they just didn't feel it was still 100%. So I just wanted to get a bit more out. We can see the whole hammer bone. I think at the beginning of the procedure probably didn't. So I'm just using the endoscope, I'm going into the ear, I'm using the left-hand side of the endoscope to push the cartilage, the first bend on the left-hand side of the ear canal near the entrance, to the left to stretch open the ear, and only then can I insert the fine end suction tip into the ear. If we didn't stretch the ear open in this case, you just wouldn't be able to insert the instrument. And although the side of the endoscope, the left-hand side, is pushing against the left-hand side of the ear canal, I've angled the endoscope almost at 1 o'clock once I'm in, so we can look into the recess. So again, just going to go in with the fine end suction tip. There's just a little bit left. So I've managed to get it into the anterior recess. And bring that away. So although it wasn't a lot of wax, and there's still a little bit left there still, it did make a big difference to this patient's hearing. Sometimes you have a bit of wax left on the eardrum and it doesn't affect the patient. But in this case it did. So again, you can see the curl, the bend on the fine end, just going into the recess. I've just got another piece out there, and that's the procedure complete. And so this is the view that I got with the wax scope. So I'm really stretching open that first bend. The second bend is just to the right, and I'm orientating the wax scope towards the anterior recess, and you can only see half the eardrum. And that's, in fact, got a better view with the wax scope, much better view compared to head loops, and also the ENT microscope in this case. So it just shows you the benefit of the endoscope. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon.